Thank you for joining us, everyone. Today, we're talking about hidden similarities and differences, insights into genetic diversity. This webinar was organized by Karen Weatherholt, Illumina's VP of Talent and Diversity, and I'm Erin Gordon, VP of Clinical Operations at Genome Medical. I'm excited to talk to you today about genetic diversity. We're going to think through this in a number of different ways. So we often think about genetic diversity on a population level, and we think of this based on our ancestors, where whatever is in our family lore of where our ancestors may have come from. And people tend to have this information passed from one generation to the next. They may have documentation on immigration and some cultural ancestry. But that tends to be the limit of the information that we have. So if a family knows that the great-grandparents were from Italy, they see themselves as Italian, they believe that's in their DNA. But there's actually a lot more to it than just that. And genetic diversity is actually quite complex. So as some of you may know, there's evidence to suggest that all humans have started in Africa and then migrated throughout the world. And this migration pattern puts us in a position where we actually share, because of that common ancestor, those common roots, share the majority of our DNA in common. We actually share 99.9% of our DNA. And any two people only have about 0.1% of the entire human genome that's different. That's not very much when you think about it. We do have 3 billion nucleotides in our human genome, so 0.1% is not an insignificant amount, but at the same time, it really suggests that we have much, much more in common than we have differences. So that commonality could suggest to some that ancestry doesn't matter. And I want to talk a little bit about why that information is important in some cases in terms of healthcare. So don't throw away your DNA test kit just yet. Just a brief reminder that your genome is basically a book. It's the instructions that make you, you. It is made up of a string of letters. Those letters, just like a book, are organized in different ways. On one level, they're organized into chapters, which could be considered the chromosomes in our DNA. And then within each chapter or chromosome, there are a number of genes. So the small differences in our genetic makeup that we might see in those individual genes, where we can see a change in a single letter, can come from various sources. They could be caused by a new mutation, so a sporadic change that emerges in the sperm or the egg cell that created you. And in those cases, it is not inherited at all. It is something that is unique to you. In other cases, we have inherited changes. Sometimes these changes are inherited in a dominant fashion, and typically variants that are inherited in a dominant fashion are visible from one generation to the next, either in the form of traits, hair color, eye color, or in the form of disease. In other cases, we inherit recessive changes, and variants that are inherited in a recessive fashion are basically hidden in the background of your genes. Someone only expresses this condition if both parents are carriers. And there's lots of changes that we'll talk about that are more common in certain ancestral groups or ethnic groups that are recessive in nature, and they get propagated generation after generation, either because they don't have a harmful effect on the carrier, or in some cases, because they actually have a positive impact. There was one question asking about if this will be available to, this presentation will be available to read. It will be. We are recording this presentation, and it'll be up on the Genomics Resource Center website for you to be able to access in the future. So where do these inherited changes come from, and how are they more common in a population, or why are they more common in a population? So genetic changes end up being more common in a population due to genetic bottlenecks. So you could have a large population, and then there could be some type of natural event like disease or famine or a natural disaster that seriously limits or reduces that population. And suddenly that changes the distribution of alleles that are left in that population. So if the population shrinks dramatically, and you have in this now much smaller population, one person who carries a genetic disease or two people who carry that genetic disease, those couple of alleles are going to be more common as that small population, the surviving individuals, reproduce, and it changes the distribution of alleles in a population. You can see in this image that in the bottle all the way to the left where it says parent population, there's a much higher percentage of yellow marbles in that bottle than in the next generation. And that's because there were more blues that came through that reduction in population. In some cases, that's random chance. And in some cases, it's because there's something advantageous about those particular genetic variants. So for example, in the African American community, sickle cell disease is more common. Having sickle cell trait, so being a carrier for sickle cell disease, actually makes you resistant to malaria. And because of that advantage that is associated with that particular genetic variant, it has become more common in the African and African American populations than it is in other populations. Similarly, if you have a migration event where you might have a large kind of mainland population and a small subset of that population moves to an island, as is the case with Iceland, for example, you end up with a smaller population reproducing on that island, tending to intermarry on that island, and being relatively isolated. That means that whatever genetic variants were more common in that population are going to continue to propagate. And in some cases, those types of changes are benign. There are things like traits. So why you see in some island populations or isolated populations, people look more similar. They all have a similar hair color. They all have particular traits that are particularly common. Things like attached or unattached earlobes. Fun traits like being able to curl your tongue or having a widow's peak. These are things that, while we don't think of them, they're certainly not disease traits. They don't cause concern. But these are genetically driven traits, and they're very common in different populations, and they tend to cluster in the same way that genetic diseases do. So variants that cause these types of traits are benign. And there are lots of different visible traits, things like variants that contribute to skin color. These types of things make us think that we're more different than we actually are. They make us think that we're more different than that 0.1%. But they're relatively harmless, right? They might drive our way of thinking, but they don't actually impact health. They don't impact adaptability or survivability. The changes that we should be more concerned about are those that are associated with disease. And just like we see different traits clustering based on different populations. We also see disease. So for example, in the Caucasian population, particularly in Northern Europeans, cystic fibrosis and SMA are more common. In African Americans, I had previously mentioned sickle cell disease, but there's also other blood disorders like thalassemias, which are hemoglobinopathies, as well as CF and SMA. There are a variety of different disorders in the Ashkenazi Jewish population, alpha thalassemia and beta thalassemia in the Asian population, as well as in the Hispanic and Mediterranean populations. And our recognition of the different diseases that tend to cluster in different populations have driven some recommendations around medical management. So for example, the American College of Obstetrics and Gynecology recommends carrier screening for all of the disorders that you see here with a solid blue dot. And the American College of Medical Genetics and Genomics recommends carrier screening for all of the disorders you see here in those populations where there's a solid green dot indicated. The open circles represent when there's an indication those tests are recommended, and then the gray dots are other society recommendations. These society recommendations came from the fact that we see that these conditions are more common in certain populations, and they've really driven a lot of our approach to testing over the last couple of decades. But that has started to change, and that's part of where I want to talk about the similarities between individuals and some of the things that are contributing to the not lack of diversity, but kind of the diffusion of diversity across the population. So part of the problem in applying these screening guidelines and thinking about ourselves distinctly as one ancestral group or another is that there's really no standard for how much of a certain ethnicity should prompt screening. So this is where, although, as I said in the beginning, we often think about our ancestors and our grandparents or great-grandparents as driving our ancestry, our ethnicity, we sometimes don't know as much about them as we would like. We don't know much about great-great-grandparents or beyond. And our knowledge of our ancestry is shaped only by what has come through the information traveling through our family. And there's lots of families out there where this information is missing for any number of reasons. So the American College of Medical Genetics and Genomics had published a practice guideline in 2008 around carrier screening for individuals of Ashkenazi Jewish descent. And recognizing that families mix and that individuals don't always know all of the information about their families, what they had said was that one Jewish grandparent is sufficient to offer testing. Now think back to this chart for a moment and imagine you have one grandparent who you know is Caucasian, maybe you have one grandparent who you know is African American, one grandparent you know is Ashkenazi Jewish, and maybe you have another grandparent who's Asian. You have a very ancestral, diverse family. If we think that one grandparent is sufficient to offer screening, then there's going to be an increasingly small number of individuals who should just be offered a single test, which is how these recommendations were originally developed. So we know that many of the assumptions about disease risk based on ancestry are flawed. Patients may have inaccurate knowledge of ancestry. So in one survey with 99 participants, so a relatively small group, 9% didn't know their biological parents' heritage, and 40% didn't know the heritage of all 4 grandparents. 40% is a pretty significant number. Again, a small sample size in this survey, but I would say that that's not inconsistent with what many of us who are taking family histories in clinical settings hear, which puts you in the position as a healthcare provider wanting to offer the appropriate test to say, well, what is the right test for this individual if they don't know what their ancestry is? Should I assume that it's a type of ancestry that would warrant the most comprehensive test? Should I assume if they look like they're like they fall into a certain group, that that's the right category to assign them? And as you can imagine, there are lots and lots of flaws to that approach. Increasing interethnic marriages result in increased prevalence of carriers. So in one study, patients that reported African ancestry had an average of 12.4% European ancestry and 79.3% African ancestry. That reinforces the idea that we're all a little bit mixed. And in another study, the variability was even higher in patients who reported Latin American ancestry. Finally, and maybe most importantly, genetic conditions don't solely exist in specific ethnic groups. Although we can identify particular ancestral or ethnic groups where disease is more common, that usually doesn't mean that it doesn't occur in other populations. It simply means that it is less common in those other groups. And so if you look at a family, particularly a couple, and you're thinking about carrier screening for reproductive purposes, that could imply that you should only offer, you could think, well, I'm only going to offer the Jewish member of this couple carrier screening for Jewish genetic disorders. But if and say, okay, if their partner isn't Jewish, we don't have to worry about it, because in a recessive disease, you only have an affected child if both parents are carriers and both parents pass the variant on to their children. The issue there is that it's not that Tay-Sachs, which is traditionally thought of as a Jewish genetic disease, can't occur in other populations. It just occurs less frequently. And so making the assumption that you don't have to test individuals of other ethnicities for disorders that are more common in one specific group means that you're highly likely to miss a lot of individuals. And there was a study done in 2016 that found just this. So this is a busy table, which I realize is probably pretty small on your screen. And so I'll sum it up to say that in most racial and ethnic categories, which you can see down the left-hand column, the risk of severe and profound conditions outside of the recommended guidelines for testing was greater than the risk identified by the guideline-based panel themselves. So let's just take East Asians, for example. They are the fourth row in this chart. So if you followed the guidelines for East Asians, the ACMG or ACOG guidelines, you're going to find the risk that would be associated with about 6% of pregnancies. There are about 94% of pregnant, I'm sorry, I'm saying that, that's going to sound like a higher risk than it actually is. Among affected pregnancies in that population, you will miss 94% of them by only testing those individuals based on the ACOG or ACMG guidelines. So again, just to make sure that I'm not sending an incorrect message here, the guidelines are so specific and narrow and really miss risk that might be present otherwise. So if you look at individuals or pregnancies that are affected with a Jewish condition, affected with a genetic condition, you only tested for those that are recommended in the ACMG or ACOG guidelines, you'll miss 94% of affected pregnancies. To be clear, most pregnancies are going to be unaffected. So you can see in the far right, 1 in 770 pregnancies is affected. But those affected pregnancies would mostly be missed if only following the guidelines. And so this recognition of genetic diversity and the fact that ethnicity-specific guidelines implies that we are less diverse than we think we are, and that we are truly independent populations as opposed to one really mixed population, has led to some significant changes in carrier screening guidelines. So a joint statement from several major organizations, the American College of Medical Genetics and Genomics, the American College of Obstetrics and Gynecology, the National Society of Genetic Counselors, the Perinatal Quality Foundation, and the Society for Maternal Fetal Medicine, all recognize that expanded carrier screening that offers the same testing and usually panels of 100 or more conditions to all populations rather than condition-based or ethnicity-based screening is a reasonable approach for all patients. And this statement was made in 2015, recognizing it's very difficult to pigeonhole an individual into one specific ethnic population or ancestral population and say, by doing this one test or this small panel of tests, we're going to find all of the possible risks that we might be worried about. We see now that people are a mixture of lots and lots of different ancestral and ethnic groups. There have been lots of mixture over the years, and that looking at it through that very narrow ancestry lens is probably not sufficient. Now, I've made lots of references to carrier screening so far, but it's important to note that the impact of genetic diversity is not limited to carrier screening. There are examples of genetic diversity and the ancestry-based testing and different founder mutations outside of reproductive health. This information can impact hereditary cancers, neurologic disorders, cardiac disorders. Disorders may have significant health implications. So I wanted to discuss briefly one example in hereditary cancer. This image from the National Society of Genetic Counselors shows why ancestry is important. So for example, in the Ashkenazi Jewish population, there are 3 mutations prevalent in BRCA1 and 2. These 3 mutations together are seen in about 1 in 40 individuals of Ashkenazi Jewish descent. That doesn't mean that mutations in BRCA1 and 2 are not prevalent outside of the Jewish population, but simply that these 3 mutations are more common in the Jewish population. So it's useful to know somebody's ancestry, but it should not be the single deciding piece of information for how to proceed. So there are thousands of mutations in these 2 genes in the general population, and about 1 in 300 individuals will carry a change in BRCA1 or BRCA2 that increases their risk of cancer. Testing somebody who's Jewish for the 3 common mutations will find the majority of these cases. However, testing someone who is not Jewish for only those 3 mutations will miss most cases. So it could change your approach to screening. For example, someone who is Ashkenazi Jewish, there are cancer guidelines that suggest anybody with breast cancer or ovarian cancer with Ashkenazi Jewish descent should be offered testing for BRCA1 and 2. And the guidelines are a little bit more stringent for the general population because the frequency is less. But you would not want to offer somebody who's Jewish just testing for these 3 mutations, because there are people who carry mutations outside of these 3. So using this information to help think about who should be offered testing or when should testing be offered, but not necessarily driving the test selection, is an important consideration that genetics professionals consider when evaluating what tests to do for who and when. I want to mention a few of the noteworthy founder mutations. I've already mentioned a few of them, but I think I saw this question come up as well about advantageous traits. And so you can see here some of the variants that are common. There's a variant in the HFE gene for iron overload, which is more common in Northwest Europe, as well as throughout Europe. And this offers some protection from anemia. The variants in the CFTR gene, which cause cystic fibrosis, are present in Southwest Europe and across Europe, and they can offer protection from diarrhea. We've mentioned sickle cell disease and protection from malaria. There's also an ALDH2 gene variant that's present and common in East Asia, and that offers protection from alcoholism. There's also other variants that influence an advantage against animal milk consumption, protection from sepsis. So many of these variants that have arisen over time and become more common over time, as I mentioned earlier, do provide an advantage that helps this variant continue throughout the population. So how can this information be used? What's the value of thinking about genetic diversity in this way? Recognizing that ancestry can play a role in health, but should not be the sole decision maker. If you're asked for your ethnicity or race in a healthcare setting, ask how that information will be used. You don't, given our recognition of the diversity in our population, you don't want ancestry alone to be used to eliminate a possible diagnosis for someone to ever say, well, you can't have that disease. We're not going to follow up on those symptoms. You can't have that because that only occurs in this ancestry. We know that that's not true. Ancestry should not be used to make decisions about test selection, but it might be used to help identifying underlying disease more quickly. We talked earlier about carrier screening and different, the prevalence of different genetic variants in different populations and the move towards expanded carrier screening. Everybody planning a pregnancy should talk to their healthcare provider or a genetic counselor about expanded carrier screening. It is now the standard of care, although there are still a lot of healthcare providers who follow the older guidelines on ethnicity-based screening. Don't let assumptions be made about you or your partner based on assumed ancestry or a one-size-fits-none guideline. So we know that more people will be found, more at-risk pregnancies will be identified if you have expanded carrier screening and have access to that additional information. I've stressed here everyone planning a pregnancy because information about reproductive planning is most helpful when you have access to it before pregnancy rather than during a pregnancy. Carrier screening is often done early in a pregnancy, but can be done prior to. Finally, work with your healthcare provider or your genetic counselor to ensure that you have the right genetic testing based on what's known or unknown about your ancestry. Ancestry alone should not be the driving force. If you have questions about your genetic risk, you can always contact the Genomics Resource Center. The services are provided by Genome Medical. We are an independent nationwide medical practice. We can offer services to patients throughout the United States, and we can offer peer-to-peer consultations with healthcare providers outside of the US for Illumina employees that are based outside of the US. And the services are fully sponsored by Illumina. However, I'll note that for your privacy, no individual level information goes back to Illumina. Illumina does receive information on the number of inquiries we receive a month, the number of consultations that we do a month, but they don't receive any employee level or individual level information. So feel free to visit the website genomemedical.com/Illumina, and you can connect with us via chat, phone, or email and schedule an appointment through that site as well. I will go back to the questions that some people have submitted. So one person indicated that he and his sister both did ancestry-style DNA testing and the results were different. How does that work? So there's a few things that can contribute to differences in individuals, differences in siblings and brothers and sisters. What is most common is that you and your sibling are a combination of your parents, but you're not identical combinations of your parents. So on average, you and your brother or sister share 50% of your genes in common. If you think about the fact that mom has 2 copies of every gene and dad has 2 copies of every gene, you and your sibling could have received the same one from each of you received copy A from mom and copy A from dad, or you could have received copy A from mom and your sibling could have received copy B. And if the same thing happened with dad's genes, that's how you end up with some differences. And so when ancestry testing is done, it's looking at markers throughout the genome. And if you happen to receive some markers from mom or dad that your sibling did not receive, that could contribute to differences in the percentage of your ancestral makeup. Now, we wouldn't expect that to be a dramatic difference. So if there are dramatic differences, so tens of percentages difference in your ancestral makeup, I would say reach out to us through the Genetics Resource Center, and we're happy to follow up with you and talk through the feasibility of that and what might have contributed to those differences. But when you see a 5% difference, that tends to be just based on markers that were inherited differently from one parent versus the other between you and your sibling. Another question was about advantageous traits. We've already talked about that. There was a question about, do you distinguish between Black Americans and Africans or between Black Latinos and Brazilians? So Black Americans versus Africans, from an ancestry testing perspective and what would be offered based on ethnicity-based screening, we don't tend to make much of a distinction there. But as was pointed out in one of the slides, Black Americans tend to have a higher percentage of European DNA than Africans would be expected to. And that, again, is what contributes to us changing our thinking about ancestry or ethnicity-based screening versus just thinking about it at a very broad race or ethnicity level. And the same would be true for Black, Latinos, and Brazilians. Different groups have different levels of admixture based on the history of those countries and the ancestral diversity of those countries. The more we recognize that, the more that pushes us towards what's referred to as pan-ethnic screening or expanded carrier screening. Why are European Jews so susceptible to different diseases? So the Jewish population in particular has gone through multiple genetic bottlenecks where the population has been reduced fairly dramatically. And on top of that, the Jewish population tends to be fairly genetically isolated in that the Jewish community tends to marry within the Jewish community. And so when you go through a genetic bottleneck and you have a few individuals who are carriers for a particular disorder, and then that population starts to grow again, and you don't have mixture from outside communities, then those genetic diseases tend to populate and become more common and more common. The flip side of that is that the Jewish population has been doing genetic screening for a long time and was one of the earlier groups to embrace carrier screening. And at this point, there are actually less, even though Tay-Sachs disease, it has historically been considered to be a Jewish genetic disease, a disease that's more common in the Jewish population, where about 1 in 25 individuals is a carrier. The screening programs for this condition in the Jewish population have been so good for so many years that there are actually now less babies born with Tay-Sachs to individuals in the Jewish community than there are outside of the Jewish community. Again, reinforcing the idea that just because a disease is not common in a particular population doesn't mean it can't occur in that population. And again, suggesting that the artificial lines we draw between ancestral groups and the decisions that sometimes leads to with respect to ethnicity-based screening is maybe not the best approach because it means we miss a lot of people. I don't have an Ashkenazi Jewish gene, but even simple characteristics like having curly or straight hair was wrong when I did 23andMe. What can be the cause of that inaccuracy? So if you look closely at reports from companies like 23andMe, particularly around traits, what you'll notice is that there are not single variants that drive 100% of a trait. So there are lots of things that contribute, lots of different genetic variants contribute to curly hair. And 23andMe and other similar companies in their reporting estimate a likelihood of having a particular trait based on your genetic variants that were observed in the testing that they did. It's not considered to be, it's considered to be recreational and certainly not diagnostic. And two, 23andMe, to their credit, I think does a very good job of including a lot of the caveats associated with their testing. The information is there, but it definitely needs to be read carefully. So this is true for both traits and their wellness reports, and as well as their disease or health-related reports. Everything has a caveat to it and a limitation. For example, when we talked previously about 3 common mutations in BRCA1 and 2 in the Jewish population, when 23andMe says that they do testing for BRCA1 and 2, they actually only look for those 3 mutations. And if you think back to the slide that I had up before, those 3 variants are insufficient for for somebody who is not of Jewish descent. They don't identify the majority of cases. And so just like with traits like hair and predictions around curly hair, straight hair, it's very important anytime you do a consumer-directed genetic test to read the limitations of that test very carefully and any precautions that the testing lab provides. If you have any health related questions, please feel free to use the Genomics Resource Center and we can help order diagnostic grade testing. There was a question about the purpose of a genomics consultation and what data is being used. So Genomics Consultations are available through the Genetics Resource Center. They're definitely, the expectation is that we're here to support you in whatever your medical questions are. We can support genetic testing, a genetics consultation, and if appropriate, testing if there's a medical indication. We also will support individuals who are looking to use genomics to be proactive about their health. It's important to note that testing, the cost of testing is not included. If there is a medical indication for testing, that can be billed to your insurance. And if it's proactive screening, that's something that could be available as an out-of-pocket expense for you. But the cost of the genomics consultation will be covered by Illumina. Couple of questions about access to slides, which we're happy to make available. And there was one more question about are individuals of Jewish descent at an increased risk for miscarriages? In general, the disorders that are more common in the Jewish population are not necessarily associated with an increased risk for miscarriages. They tend to be early childhood onset disorders that have some significant neurologic involvement and often lead to early death in childhood, but are not associated with an increased risk for miscarriages. And so if there's a concern about a personal risk for miscarriages, we'd be happy to talk to you individually as a consultation through the Genomics Resource Center, where we can better assess your personal risk and identify if there's a particular test that might be appropriate to help understand what's going on in you or your family. There was a question about, is ASD curable by precision medicine developed through genetic screening? I'm assuming that ASD in this case refers to an autism spectrum disorder. At this point, autism spectrum disorders are not curable. The best management options right now for autism spectrum disorders involve early intervention, but there is not a cure. There are many other genetic diseases where there are gene therapies that are in development. Some of those include either in development or actively accessible right now. Some of those include sickle cell anemia, cystic fibrosis, Duchenne muscular dystrophy. And so the progress that's been made with respect to identification of genetic diseases and then treatments for genetic diseases over the last 20 years has been absolutely remarkable. But unfortunately, autism spectrum disorders are not yet curable through precision medicine. I think with that, we are at the end of the list of questions. I want to thank everybody for attending. We look forward to continuing to serve you and answering any questions that you might have through the Genomics Resource Center. And we will be making this recording of this webinar available through the Resource Center in the next day or so. If you have any questions, please don't hesitate to reach out to us. Thank you so much for attending. Have a great day.